Welcome to ParkOn 2021. Thank you very much for joining this session, where we'll be looking into some of the current treatments for Parkinson's, including those with medication and those without. So I'm your host for this session. My name is Clare Addison. I'm a mum, I'm a wife, and I'm a nurse, and I was diagnosed with Parkinson's disease 5.5 years ago. Currently, I'm working as a specialist nurse for safeguarding in my local hospital, but I'm also co-lead the South East Parkinson's Disease Excellence Network. Today, I'm pleased to be joined by Professor Richard Walker, who's a consultant physician in North Tyneside and also clinical lead for the Northumbria Parkinson's Disease Service, and also joined by Andrea Strutt, who's a Parkinson's disease specialist nurse, also from the Northumbria Parkinson's Disease Service. I'm really looking forward to hearing their thoughts on what the future may hold for us in terms of treatments and care. But before we dive in, just a couple of bits of housekeeping for those of you joining us live. We'd love to hear from you, so please do share your thoughts, reflections and comments in the chat. And finally, if you missed the start, you might want to watch this session again, or if you have any technical issues, don't worry. All the conference content will be available to watch on demand for 30 days after the event. The session has been split into 2 talks, and there'll be lots of explanations. The first half will focus on drug treatments, including the different types of drugs on offer and how they work. And this will be followed by a small question and answer session between myself and Richard. The second talk will focus on the non-drug treatments, such as surgery, physiotherapy, as well as explaining some of the symptoms that these treatments can address. And again, short Q&A after that, and you can raise a question using through as many as we can. And now I'll hand over to Richard to kick off the first talk. Thank you.
Well, thanks very much for that kind introduction, and it's a real pleasure to be talking at this meeting today. So I'm going to talk a little bit about the drugs that we use for Parkinson's, a bit about the different drugs that we have, what their effects are, what their side effects are, and why we use different drugs at different times for treatment. So this relates back to Parkinson's disease NICE guidelines in 2017. So this was an update from the original guidelines in 2006. And actually, I was a representative on these NICE guidelines. So what we did was we looked at all the evidence about the different drugs that are used for Parkinson's and tried to put together our advice for clinicians about how to use the drugs and when to use them. And the main thing that we came out with was that first-line treatment for people with Parkinson's should actually be levodopa. And this is a drug, as you know, has been around for many, many years. And the majority of people with Parkinson's will be on levodopa, at least at some stage during their Parkinson's disease. It also says we would offer a choice of dopamine agonists or monoamine oxidase inhibitors in early stages of Parkinson's. And these, again, can be used on their own, just like levodopa can. And what I'm going to do now is just explain a little bit about the different drugs and when we use them. And we'll talk about another set of drugs called COMT inhibitors, which have to be used with levodopa. So these are the 5 different drug classes that we have to use. So levodopa, we've mentioned briefly. Dopamine agonists, we will talk about monoamine oxidase B inhibitors, what we call COMT inhibitors, and anticholinergics. So if we look at how these drugs might be working, the bottom line of all of this is people with Parkinson's are short of dopamine in the movement center in the brain, in the basal ganglia. So what all of these drugs are trying to do is to replace that. It's a bit like replacing, for people with diabetes, replacing the insulin that they haven't got. So we're replacing the dopamine, but we're replacing it specifically in a particular area of the brain. So if we think about levodopa first, we give that as a tablet. It crosses the blood-brain barrier. It doesn't get broken down before that, but once it's into the brain, it gets broken down to dopamine. So that's the active agent, and that stimulates the receptors. So that's how levodopa works. Dopamine agonists work by actually stimulating the dopamine receptors directly. So they don't use dopamine or whatever. They are, if you like, mimic dopamine and stimulate the receptors that way. And then the other classes of drugs are the MAOIB, so that's rasagiline or selegiline. And what they do is they stop the breakdown of dopamine, so it makes it last longer. And they do it in different ways by affecting different enzymes. But the key difference between them is that the MAOIB inhibitors can be used on their own, whereas the COMT inhibitors can only be used with levodopa. And just looking in a bit more detail about the dopamine. So the levodopa, as you can see, crosses the blood-brain barrier and then gets broken down. But what we have is a very clever ingredient of the levodopa at the bottom there, the dopa decarboxylase inhibitor, which stops the levodopa being broken down before it gets into the brain. So that means that we get as much active ingredients into the brain as possible. And then it explains there also that the COMT inhibitors work peripherally and prevent breakdown of the dopamine. Okay, so if we think back to the history of levodopa, you are very lucky to have been born after the 1960s, because before the 1960s, there was very little that we could do for people with Parkinson's disease. But what was invented in the 1960s was levodopa, and the key ingredient, as we've been describing, was this decarboxylase inhibitor, which meant that levodopa could be used and its potential could be maximized. Now, we've now used the levodopa for over 50 years. We know what its effects are. We know what its side effects are. It's not perfect, but it is still the most efficacious drug that we have for Parkinson's disease. And there's lots of different ways that we can give it. So some people will be on, most people will be on standard release tablets. And what we always do is start at a very low dose and very gradually increase it. So like all the drugs for Parkinson's disease, it can make you feel a bit nauseated and it can make you feel a bit dizzy. But if we start at a low dose and gradually increase it, usually these effects are pretty mild. And there's no dramatic hurry to getting up to your maximum dose. All the drugs that we use to treat Parkinson's don't actually change the Parkinson's itself. We just replace the dopamine at the time. So we treat the symptoms, but we actually don't stop the disease itself. And as you know, it is a progressive disease that gradually you lose more dopamine receptors over time. So over time, we need to give more and more drugs and different types of drugs to people. So then thinking about the different preparations, there's a CR preparation, which is a controlled release. So that's longer acting. We often use that at nighttime. So when people might take that when they go to bed, it means that they would work if they have to get up in the night to go to the toilet or something. There's a dispersible preparation, dispersible Madapar, which is a dissolvable one. That's the fastest acting we can give. So we often give that for people if they get problems with wearing off, that they can take that and that will relieve things fairly rapidly. There's about to come to market an intranasal preparation that is used in some parts of the world, not currently in the UK. But the other thing we can do is sometimes if people can't swallow, and this may be a problem if they're in hospital, is we can actually we can put a tube down and actually give the levodopa via a tube. So thinking that problems that might occur, sometimes people get decreased absorption. So one of the things we can do is you can take the medication away from meals and that will improve its absorption. People will get wearing off after a while. So the effects of the drugs wear off before your next dose is due. Your tremor might get worse or you might slow down. So what we do is move the doses closer together. And then we get these peak dose effects called dyskinesia, where people get a little bit restless and fidgety. And what we'd aim to do is kind of lower the overall dose or spread it out through the day. So coming on to dopamine agonists, so many people will be on these. So the main ones that people will be on are the top three there. That's ropinirole and pramipexole. Both of those can be given 3 times a day, but both of them now have slow release preparations, which most people will be on, which can be given once a day. Then there is the patch, which some people prefer. This is, you wear it for 24 hours. We found that particularly helpful in hospital for people who can't swallow. So it's a way of us treating people if they can't swallow temporarily. And then there are other drugs that we used to use in the past, like bromocriptine, pergolide, and cabergoline. We do not use those anymore because of the side effects that they have. And all of us, the dopamine agonists work in slightly different ways to each other, which is why they have different effects and different side effects. So there are lots of different receptors. There are 5 different receptors, and they'll affect them in different ways. Levodopa itself, the dopamine will stimulate all of the receptors. And the thing that's got a lot of publicity about dopamine agonists is this impulse control disorder. It probably occurs in less than 10% of people with Parkinson's who get dopamine agonists. But we always warn people about this when we start the drugs. And we also warn their carers, because it's a sort of thing that a person with Parkinson's may be less aware of. And actually, sometimes it's compulsive. So it's a bit like people gambling and they can't stop gambling and such like. So it's important that we make the family aware of these potential side effects. And all of those things that I've described there, gambling, sometimes hypersexuality, sometimes overeating, sometimes shopping. And so just to be really important to be aware of it. It can occur with all of the drugs for Parkinson's, but particularly with the dopamine agonists. So that just gives you an example of some of the things that can happen with impulse control disorder. So if we go back to the NICE guidelines again, when the original NICE guidelines were written, this wasn't really an issue. It was only in the last 15 years we've become more aware of this. So when starting dopamine agonists, people should be told about the potential for this. And we should, when we follow people up, we always ask about this. So just so that people are aware of it. So if you have problems with like this, let your medical team know, and they will adjust your medication. And then we mainly do it by adjusting medication. There are other things that we can do. And again, this is what the NICE guidelines have to say about it. Okay, so then going on to the other medication we can use, the COMT inhibitors. So you remember, these are the ones that stop the breakdown of dopamine. So they prolong the action and increase the action of dopamine. And these can only be used with levodopa. The one that most people will be on is something called entacapone. You take it with every dose. There's a combined preparation called Stalevo, which includes the entacapone and the levodopa. Thing to be aware about that is sometimes it causes diarrhea, but the thing it always causes, it makes your urine and saliva go orange. So you should be warned about that, but just don't get alarmed about that. Tolcapone, we hardly ever use because we have to do regular tests for liver function. The other one that's new that is available now is opicapone, which is a once daily preparation. And then the other ones that decrease prolong the action of the dopamine, but can actually work in their own right, are the MOAB inhibitors. The things that people will be on for this is selegiline and rasagiline, both of which are off patent, so are reasonably inexpensive, and safinamide, which is the latest one, which has been available since 2018. Particularly aware with these ones that they can cause a drop in your blood pressure when you're standing, and they can specifically cause hallucinations. All of the drugs that you use can cause hallucinations, but these are perhaps a bit worse than the other ones. And then the fifth group that I mentioned to you was anticholinergics. And it's really just to say, we hardly ever use these just because of their side effects. So particularly side effects in relation to things like hallucinations and such like. But they are the most effective ones for tremor. And tremor is actually the least responsive symptom to drug treatment. Just a couple of other drugs that people might be on. So amantadine was originally developed to treat flu, but it also has a mild effect on Parkinson's. It's particularly helpful for people who have dyskinesia. So that's when we tend to use it. But it is quite a potent cause of hallucinations, so you just need to be aware about that. You can't take it after 2 or 3 o'clock in the afternoon because it'll keep you awake. Apomorphine is a dopamine agonist, but we can give that by a subcutaneous injection or a subcutaneous infusion. So some people might be on that. Usually people are on the infusion, so it's an infusion pump that you can wear on a belt. And then the other thing to mention, which very few people will be on, but you will have heard about, is something called duodopa, which is actually just levodopa, but it's put directly into the intestine just beyond the stomach via a tube. Very effective, very expensive, and obviously quite invasive. And then, there are different guidelines that people use for treating Parkinson's. So we might start with levodopa, we might start with an MAIB, we might start with a dopamine agonist, but invariably we'll start to add other drugs in as the disease progresses. And towards the end of later stage disease, we often end up balancing the effects of the drugs against the side effects in order to best control treatment. And the key thing about optimizing drug therapy for us is working with people with Parkinson's and actually working out what it's like living with Parkinson's and potentially juggling the medication and enabling you to change the medication in order to get the best control that you can with the drugs that are available. And we do have quite a few drugs, as I've described, that we can use. So just a couple of thoughts at the end of this is just, I've got a very big interest in Parkinson's disease in Africa. And so I would say that you're very lucky to be in the UK, because you can access all these drugs and they're on the NHS or whatever, and you can access multidisciplinary teams. And you don't have to worry about too much about the cost. But from our previous work in Africa, we think half the people in the world with Parkinson's haven't actually got treatment for it. But there's an interesting thing called Mucuna pruriens, and some of you may be on this. You can buy it on eBay. They are beans that grow ubiquitously in the tropics, and actually they contain levodopa. And if you roast them, shell them, and grind up the powder, you can use them. So obviously you can buy this on eBay, but it's quite expensive. We're very intrigued to see how we can actually do this at scale in places like Africa, to see how we can actually give other people access to drug treatment. And thank you very much. So I'm going to leave you with a nice picture from the Northumberland coast. This is Dunstanburgh Castle, if anyone's visiting Northumberland. Thank you very much.
Richard, thank you very much for that interesting talk. I don't know about everyone else that's listening, but I've certainly learned an enormous amount of new information in hearing you speak. But it does throw up some questions for me. It's obviously a huge balancing act, and I guess you inferred just now how important it is that we as individuals with Parkinson's understand our disease so that we can help inform you as to our challenges, to help guide you in your prescribing of medication. Is that correct?
Absolutely. So, I mean, when you come to the clinic, we'll ask you about whether you have problems with wearing off, whether you've got problems with dyskinesia, the things that we've been talking about. We'll always ask things like hallucinations. A lot of people get hallucinations but aren't necessarily particularly disturbed by them. And we'll also ask about impulse control disorders. And if there's a pattern that we can sort of look at, like we may find that every afternoon you feel awful or your tremor gets really bad. So then we can then adjust the drugs so that we can actually, maximize the effect of the drugs at that time of day, for example. So it might be a question of giving you an extra, if you're on levodopa dose then, or if you're on dopamine agonist, maybe just increasing the overall dose. So absolutely, very, very important that people can actually, before they come to clinic, just think actually, what is there a pattern to the day? Are there things, times when I'm feeling better, times when I'm feeling worse? Because we can only see what we see in the clinic, and that's a snapshot really. So we're very reliant on the story that you tell us as to how it is living with Parkinson's.
Yes, absolutely. And you mentioned a few of the issues with side effects, particularly around compulsive disorders. But could you explain any of the other symptoms that we should look out for that are perhaps quite prevalent?
Yeah, so I think for all of the drugs, they can make you feel a little bit nauseated. This is why, and also a little bit dizzy. So they all tend to cause a kind of slight drop in your blood pressure if you stand up. So if you stand up rapidly, you might notice you felt a bit dizzy or something. Usually the body adapts to that, but that's why we start at low doses and very gradually titrate the doses up. And if you get really nauseated with it, then you can also take it with meals rather than away from meals, and that won't matter early on in the disease. Sometimes later in the disease, it means it's difficult for you to absorb the medication. There are drugs that we can use to treat nausea, but most drugs used to treat nausea actually make Parkinson's worse. The one that we tend to use is something called domperidone or ondansetron. Most people don't need that. Other side effect, the other side effects that don't usually occur early on but may occur later on is one of the big things that people have is these hallucinations. Usually visual hallucinations. Often people get a sense of passage, so a sense of something behind their shoulder, or may see animals or something like that.
Yes, unpleasant. And the other thing, Richard, you mentioned that within each of the drug groups that you talked about, there were several different types of drugs. And when I talked to friends of mine also being treated for Parkinson's disease, we all find we're on different names of drugs. How do doctors decide whether they should prescribe one or the other?
Okay, that's a really, really good question. So you're right. You're absolutely right. There's the different classes of drugs. And there's the three main classes that we use for starting off, and then the COMT inhibitors that we can use in add-on therapy. But also within these classes, there's different drugs and there's different formulations. So if you start with levodopa, you'll either usually be on something called cocaryl-dopa, otherwise known as Sinemet, or cobenyl-dopa, otherwise known as Madapar. They are much the same, but different people will be on different drugs. The dopamine agonists, ropinirole and pramipexole, are the ones that most people will be on. Again, as I said, they work in slightly different ways. So some people get away with one and not with the other. And then the other different one is the roticotine, the patch, if people prefer the patch. The MAOIB inhibitors is the selegiline and rasagiline. And rasagiline probably has less side effects than selegiline. That's the one we would tend to use. And then the COMT inhibitors, we tend to use the entacapone. And then coming back to what we would use to start off with, so the NICE guidelines has really reassured us that levodopa is the best drug and is, relatively safe, because a lot of people get scared of using levodopa and thinking about the side effects. And there are side effects, the wearing off and the dyskinesia. But as long as you keep to a reasonably low dose and titrate things gradually, usually those sort of side effects can be minimized. But I'll give you an example. So I saw a patient in the clinic yesterday who's a 59-year-old guy who's just presented, and we had a discussion about the different medication. And I said, well, actually, why don't we just put you on rasagiline for the moment and see how you get on? And then we'll see how he goes with that. It may be that we might then, if he gets to a point where he wants something else, use a dopamine agonist, warning about the side effects, before we then use levodopa, just because he's presenting relatively early, and there might be a benefit from delaying the levodopa. But the main message really is don't be frightened of levodopa. 8 to 9 times out of 10, that's what we will usually start people on.
Yeah, that's it's reassuring to hear that, because I know personally I was very anxious about starting levodopa and tried to put it off as much as possible. But we have to listen to our clinicians, and certainly the benefits were realised when I started taking it. Richard, thank you. That's really been really interesting and enlightening, certainly for me, and I hope for others too. Thank you. Now we will hear about the alternative non-drug treatments that are available. So over to you, Andrea.
Thanks very much, Claire, and thank you for inviting me to take part in this presentation. So I'm going to talk about the non-drug treatments that are available for people with Parkinson's. As you'll be aware, there are a number of symptoms that can be affected for people with Parkinson's. Not everyone will encounter those symptoms though, so just to try to reassure people, just because we ask about these symptoms, it doesn't mean that you will necessarily encounter all of these problems. So the motor symptoms that we see for people with Parkinson's, all shown on this slide here. Changes with speech, changes with facial expression, reduction in the arm swing, posture, a tremor, difficulty rising from the chair, slowness of movement, which is the bradykinesia, stiffness and rigidity, postural instability, micrographia, which is changes in the handwriting, difficulty turning over in bed, difficulty turning when they're walking as well, problems with freezing and some gait fascination, so changes in the walking distance and speed, shuffling of the gait, and fine finger movements such as doing up buttons as well. So these are just some of the motor symptoms. Then the non-motor symptoms, again, there are a number of these in ways that people can be affected. With the drug treatments, not all of the symptoms will respond to drug treatments, and therefore it is important to think about some of the non-drug treatments and how they can actually make some difference for people. And again, these are just some of the areas. But again, just to reassure everyone, just because they're listed there or we ask about them in clinic, it doesn't mean that you will be affected by these symptoms at any point or during your course of your illness. So as Professor Walker discussed, the NICE guidelines were updated in 2017. These were guidelines that were produced with patients and healthcare professionals involved in recommending course of treatment for people in different conditions, and actually it's all based on best evidence available. So one of the quality statements in the NICE guidelines is that people with Parkinson's are referred on to different therapists, so physiotherapy, occupational therapy, and speech and language therapists, if they have any problems with their balance, their movement and motor function, activities of daily living, communication, swallowing, or saliva control. And the rationale for this is that actually their interventions can help people manage their symptoms, maintain their independence, and also look at avoiding hospital admission if we're worried about swallowing concerns, if there's risk of chest infections, or also the balance and mobility, risk of falls. So we can actually help to try to minimise those risks for hospital admissions. So I'm just going to cover some of the different non-drug treatment interventions that are recommended in the NICE guidelines. So they recommend that people with Parkinson's should have regular access to clinical monitoring and medicines management, and they do recommend at least 6 to 12 monthly reviews. Obviously, in light of things that have happened over the last 18 months, we've all had to adjust how we perform these reviews. In the past, they were all face-to-face. We now have various different methods of reviewing patients, telephone reviews, video consultations, or face-to-face. A lot of us are back to as well now. But going forward, we probably will do a mixture of those reviews for people, because some people have found the benefit of having telephone reviews in between face-to-face assessments as well. Video consultations have been very beneficial for people as well, particularly when we've had any residents in care homes. The families want to be involved in those reviews and they haven't been able to visit. So we've actually managed to join those up and have a review with the person in the care home, with the member of staff, and also the family have got involved in those reviews as well. So I think that's been really beneficial in going forward, and I hope that that will be something that we can carry on. They also recommend a continuing point of contact for support, and that is throughout the duration of their illness. And that includes home visits when appropriate. Some of our patients will have other health conditions going on as well that can make difficulty attending clinics. They may be housebound, they may be high risk of falls, or have other factors going on as well as the Parkinson's. So actually home visits may be more appropriate at different points. And also provide a reliable source of information about the clinical factors, but also the social matters that are concerned to people with Parkinson's, but also the family members and carers as appropriate as well, because it's not just affecting the person with Parkinson's, but it can have a huge life-changing impact on the whole family at home. So looking at support for the family members. And it does acknowledge that this can be provided by a Parkinson's disease nurse specialist. One of the factors that they talk about is the intervention from physiotherapists and the importance of physical activity. The recommendations are referring people who are in the early stages of Parkinson's disease to a physiotherapist who has experience of looking after people and managing the Parkinson's condition, to provide an assessment, look at education and advice, and also information about the physical activity. They recommend offering Parkinson's disease specific physiotherapy for people who are having any balance and motor function problem. And things that they can address is looking at improving or maintaining a level of fitness, helping people to stay independent, helping to prevent or manage falls, which can be a big factor for people. And obviously, as I said earlier, that can lead to hospital admissions also. There is emerging evidence, and this is acknowledged on Parkinson's UK website, that actually increasing exercise to about 2.5 hours a week can be as important as medication in managing the Parkinson's symptoms. So just a couple of things. I do acknowledge that there is a physiotherapist talking on the programme as well. So I just want to briefly mention a little bit about physiotherapy and but that will be covered in a lot more detail. So the basal ganglia, as Professor Walker talked about, that is the area that is affected with Parkinson's, that controls movement that is automatic. And that is where the walking can be affected. So people with Parkinson's, you will all appreciate that actually you now need to tell your feet how to move. It doesn't happen automatically. You can't just stand up and move across the room without thinking about it. It can become difficult. So you do have to concentrate and think about how to actually make those movement changes. Some of the things that can be affected for people is shuffling, so small shuffly steps, slow speed, festination, and that the body leaning forward, short shuffly steps again, that festinating gait, freezing when people get to doorways, corners, any obstacles, flat-footed, so people might not find that they're able to lift their foot and they might trip easily as well. They might notice scuff marks on the side of the body, on the shoes, the side of the body that is affected more. Reduced arm swing because of less truncal rotation, less rotation in the body, difficulty turning. So people might find they can't just turn to the side automatically. The top half might start turning, but the feet will stay stuck. So the physiotherapists will look at things and techniques to try to teach people how to change the movement and how to overcome some of these problems, and also that initiation in your walking as well. We are just about to be involved in Northumbria in a study with Derbyshire as well, looking at remote physiotherapy and is that effective for people with early Parkinson's. So that would be interesting, and that hopefully will support some of the studies that have already gone on looking at the importance of exercise in Parkinson's. The NICE guidelines also recommend speech and language therapy input. They recommend offering speech and language therapy for people who are having problems with their communication, problems with the swallowing, or any saliva control problems. They can teach people how to improve the safety and efficiency of the swallowing. There's different techniques that they can advise on. Also strategies to improve speech and communication. We know for people with Parkinson's, the volume and speed of speech can be affected. If there's any breathing difficulties, that can obviously impact on communication. And obviously the facial expressions can change, that masked face-like expression, because of the changes to the muscle control. And then the articulation of the speech as well. So they can teach different strategies to try to help with improving those. Unfortunately, occasionally communication can be more problematic in the more advanced stages for some people with Parkinson's, and the speech therapist can be involved in looking at alternative methods of communication, different equipment aids that might be helpful. But this is if necessary in more advanced stages for some people, but they can be helpful in coordinating that. Some things that they do recommend about encouraging self-management is for people who have swallowing difficulties, concentrating while eating and drinking and avoiding any distractions, providing obviously having drinks with the meals as well. taking your time to chew small mouthfuls and sips of fluids, pausing in between the mouthfuls to allow time to clear the residue. Also thinking about timing of medication around meal times, as well as the movement and motor function of walking being affected as the medication's wearing off. The swallow may not be as strong and as clear at that time as well. So trying to think about having meals when the medication's more effective, to try to enhance the swallow at the meal times. Just some of the things about how communication can be affected because of slow movement, the tone in the speech as well, that can be affected, the reduced facial expression I talked about, difficulty with gesture. If people have difficulty with hand movements and movement, that can affect as well the hand gestures that can all help with the non-verbal communication. Any saliva control, as I mentioned earlier, changes in handwriting, the micrographia, some word finding difficulties, and forgetting train of thought as well. Quieter speech or faster speech, as well as the walking, the fascinating with the walking. Actually, some people can have some stammering of the speech as well. And bradyphrenia can be a slowing of thought. So it's not always that there's any memory changes going on. It can actually be slowing. You may be fully aware of what you want to get out, but it's that slowing of putting things in the correct order to get those out. And actually, there is a program that the speech and language therapist can provide, which is the Lee Silverman technique, and that is a exercise program. It's quite intense, so it does need commitment. Not all speech therapists in areas can offer this program, but it is something that has been found to be beneficial to look at the volume and projection of speech. So just some pointers for any carers who are listening in as well, just some communication tips and pointers. So just thinking about any background noise, because obviously any distraction. I know some patients, when I've discussed things with them, they find in big social settings, if there's lots of conversations going on around, that can be difficult to follow. That can affect their train of thought. There's lots of distractions going on. So actually, sometimes that can help to try to minimise that where possible. Encouraging good eye contact when talking as well, to try to maintain that contact and to pick up any non-verbal cues as well. Asking to repeat or rephrase if you're not sure or if it's not being clear, just asking to repeat and for the person to rephrase what they're trying to explain. Encouraging use of gesture to emphasise any important points. Louder voice, and that goes back to the voice program that I mentioned for the speech therapist, that louder voice, and trying to reassure people that they're not shouting. If there's no changes with hearing, you may feel that actually your speech is not affected, but unfortunately sometimes it can be quieter and more difficult. So for the person around the carers to encourage that actually they're not shouting, and try to encourage that louder voice and to reassure them. And also allowing time to respond. As I mentioned there, that bradyphrenia, that slowing of thought, that can actually delay the response. The person with Parkinson's, you know what you want to get out, but it just takes that bit of time to put the sentence in the correct order, to get those responses out. So other people around just to acknowledge and to actually allow that time to respond. Occupational therapy. This is another area of therapists that are available and very supportive for people with Parkinson's. And again, this is acknowledged in the NICE guidelines that we follow. They can offer, so it's offering people with Parkinson's disease-specific occupational therapy. So a therapist who hopefully in your area is aware of Parkinson's and how the difficulties can affect activities of daily living. They can look at different ways to do a task more easily, look at advice about strategies, techniques, gadgets, equipment, different technologies that are available. If you just let them know what you're struggling with, they will help to try and work out what might actually help. They may quite likely recommend any practical changes. If there's any layout around the home or when you're doing a certain task, they might a different person looking in recommend different changes to how you're doing something that might actually make things that bit easier. Also different cues that might help perform activities or tasks more easily, as the physiotherapist will look at cues with the walking to try to prompt any freezing episodes. The occupational therapist will look at those techniques as well. Also, help to develop strategies to cope with tasks that are more difficult and challenging as well. As I said earlier, if you just let them know what you're struggling with, they will actually look at different techniques that might be able to help with that. And also provide information, various resources, services and benefits that are available to help maintain family life. If you're still working as well, or any leisure interests that you've got, the occupational therapist can be very helpful in guiding on those areas of life as well as obviously the information support from Parkinson's UK advisors. These areas aren't mentioned in the NICE guidelines specifically in terms of non-drug treatments, but these are important things that we do. So obviously the drug treatments for autonomic features are mentioned in the NICE guidelines, but actually there's some non-drug treatments. Not every person who has some of these changes will need drug treatment. So I just thought I'd mention a couple of the things here. So constipation, as we know, it's really important for people with Parkinson's to manage the constipation because of the impact that can have on the absorption and response to medication. So simple things like increasing fibre, looking at your fluid intake, exercise, trying to keep that activity level going. Occupational therapy input, they can look at access issues to toileting areas, mobility issues, particularly if there's any problems overnight, they can look at different options that might be available to help those issues. And then you may need to look at laxative management, and we can get input from continence advisors as well. Some bladder symptoms that can be affected for people with Parkinson's. We would encourage looking at your oral fluid intake to ensure. Sometimes people find, especially if you have problems with going to the toilet during the night, some people have mentioned to me that they think, well, I'll reduce my fluid intake during the day. And actually that can have a negative effect because the bladder, it's a muscle that needs to be stretched and exercised. It can become lazy and that can add to those problems at night time. So actually trying to keep a good fluid intake during the day, and especially earlier in the day, if you want to limit it later in the evening, that can actually be beneficial. Looking at constipation, because of the close proximity, obviously constipation can have an impact on the bladder control. Looking at reducing caffeine and alcohol, and we're not saying that you have to take away that totally, but they're both stimulants and that can affect the bladder control. We can get input, like I say, from the continence nurse specialist, district nurses as well. They can help look at different aids that might be needed, or also advice about appropriate clothing. If people find they're having problems with urgency of going to the toilet for the bladder, trying to think about the clothing that you're wearing as well and what's going to be easier to try to undo when you're in that hurry getting to the bathroom as well. Just simple little things that might actually just make that a little bit of a difference for you. And then looking at the blood pressure control as well. So there is some advice that we will give initially if we know that there's some fluctuations in the blood pressure. As Professor Walker mentioned in his talk, the medication can actually cause some further problems with the blood pressure management. So we will look at encouraging good fluid intake, managing the constipation, cautionary positional changes, going from lying flat to sitting on the edge of the couch or the bed first, doing some exercises with the legs before you even make a movement to stand. All of that muscle activity in the legs does help to actually support the blood pressure. Just going back to fluid intake, we do encourage trying to, rather than just sipping a glass slowly over a period of an hour or two, actually having a good volume over about 10, 15 minutes. And that bulk of fluid does actually help to support the blood pressure control. We may then look at considering any compression hosiery if you're suitable with circulation, to try to maintain that circulation in the legs. And also they may look at abdominal binders, so a wrap that is worn around the abdomen. This is when we've looked at any investigations that are needed. So this may be more when we know there is problems with the blood pressure, and we do need to look at more investigations for that, or medication management is mentioned also. Again, this it's just some of the techniques that we may offer to discuss with people in terms of if there's any fragmented sleep problems. There is a lot of information on Parkinson's UK. There's an advice sheet there that looks at some sleep hygiene factors, and there are some things that we would recommend. So if it's difficulty turning over in bed at night, moving in bed at night, occupational therapists may look at handrails or different things, equipment around the bed. They also look at the bed clothing that you're wearing or the sheets that you're using as well. Certain ones are a bit easier to move on. Also relaxation before bed as well, that does help. Avoiding those stimulants in the evening time as well. Caffeine, alcohol and tobaccos, they're all stimulants which obviously will reduce cause more difficulties getting off to sleep. Avoiding sleeping in, so actually trying to get a good routine to the day, trying to always get up at the same time of day, and having that good routine. If you do need to rest in the afternoons, actually going and having a lie down for a good hour is much better than catnapping for 5 to 10 minutes here and there. So actually having a better plan to the day. And trying to think of all those things that actually do stimulate the mind in the evening time as well. So watching television or working in the bedroom or iPad, laptop, iPhone, they're all stimulating things. So actually trying to limit those in the last few hours before trying to relax for bed does help and does make a difference. We do try to remind everyone that actually this can take a bit of time, this can take a bit of work, it can take a few weeks of following all of these sleep hygiene techniques to actually make a difference to that sleep pattern. And also trying to limit exercise within the last few hours before bedtime as well. That can be beneficial to try to help to wind down. Again, just some techniques about managing anxiety. It can be managed, obviously speaking with your specialist about any adjustments to your medication. Is the anxiety coming in relating to any off periods? Is that part of when your medication's wearing down? Because we know that anxiety can be problematic for people at those times as well. So is that a sign that the medication's wearing off? Different ways to relax, there's various different ways. Some people find meditation, yoga, reading, listening to music, going for a walk, various different ways. It's whatever works for you in terms of finding ways to relax. Doing something you enjoy. As I mentioned earlier, just reading, listening to music, art as well. There's a lot of things about art therapy that's beneficial for people with relaxation. Maintain a healthy diet. We're not saying you have to get rid of caffeine totally, but definitely caffeine, as it is a stimulant, that can add to the anxiety as well. So just thinking, do you feel that that is adding to it for you? So some exercises can be very beneficial in terms of looking at stress and anxiety. So those rhythmic exercise of walking, swimming, that help to maintain joint activity and strength as well. And mindfulness, as I mentioned, there's a lot of different apps available there on the internet, on iPhones, to help with mindfulness and relaxation. One of the other areas of treatment, but it's non-drug treatment, that is mentioned in the NICE guidelines is deep brain stimulation. This is where an electrode delivers high-frequency stimulation, and that overrides some of the signals that cause the symptoms in Parkinson's. There's different areas of the brain that they may target depending on what the symptoms are for you, and that is very much assessed for you if you were to go along the assessment route for deep brain stimulation. It can provide effective symptom control, but as with the treatments, it doesn't provide a cure for the disease. This is usually discussed in more advanced Parkinson's cases where actually control with drug treatment is not being best managed. So there's different areas there you can see highlighted on the slide. There's the electrode, which is actually implanted into the specific area of the brain. As I mentioned, they do have different target areas depending on what the symptoms are. There's then a battery that is actually implanted just below the collarbone there. And there's then the cable that runs under the surface of the skin that connects the two. The assessment process for deep brain stimulation is very detailed. We in Northumbria would refer across to Newcastle service. They would assess patients. It's quite a lengthy process to ensure that they are thoroughly assessed. The type of surgery they are looking at is suitable for that individual patient. They have detailed assessments looking at balance and walking with physiotherapy, assessments to make sure there's no concerns that are going to be made any worse, psychology assessment, speech and language therapy assessment as well. So it is very thoroughly assessed to make sure it is safe and as possible and suitable for you if you are referred through to look at consideration for deep brain stimulation. So just to summarise, everyone's Parkinson's is unique. Different combination of medication, exercise and therapies will suit different people. It's individualised care. It's not a one-size-fits-all, and we will assess you as an individual and discuss with you what problems you're having and what treatment options, therapy options you wish to explore for yourself. And not all of the symptoms that we've discussed or you will hear about will be an issue. We will ask when you come along to clinic if you're affected by various different issues and symptoms. They will not all be an issue for you though. It is very individualised, the condition. And just to acknowledge the importance of early intervention and support from the therapists as well, and the benefits of some non-drug treatments that are available, which we've hopefully just touched on today. Information, there's a host of information on Parkinson's UK website, and that is definitely always our go-to for people when they're newly diagnosed or encounter any new features that they've not come across before. Just want to thank the Northumbria Parkinson's multidisciplinary team input for their input in the slides that I've shared today as well. And thank you for listening.
Thank you very much, Andrea. Goodness me, you have blown us away with so much information. And I guess what's speaking very loudly out to me is how important the early involvement of a wide multidisciplinary team is in us as people with Parkinson's, understanding what the challenges are ahead and how we can take ownership of some of those challenges and make a difference to ourselves. What advice would you give to people who are listening to this, Andrea, who haven't had that referral to an MDT yet, because it's not available as comprehensively in all areas and not everyone has had that opportunity as yet?
Yeah, I think if you are aware that some of those features that we've talked about are a problem for you, if you're aware of some communication problems that are coming into play for yourself, or if there's any difficulty of tasks that you're doing around the home or working life as well, such as difficulty around the home, risk of falls or any mobility problems, definitely talk to your therapist, whether that's a consultant or nurse specialist. Talk to them about the problems that you're having and what options are available.
Thank you, Andrea. And the other thing is obviously realising how important exercise is in our taking ownership of our disease management. And I was listening to a talk yesterday where they were talking about how important the intensity was of the exercise, and to the extent that you referred to in your talk, but also the importance of adding a cognitive component to that, so that you're not necessarily just going on a rowing machine for half an hour, 5 days a week. You're actually adding something that challenges the mind as well. Right. It might be that, you might be considering some puzzles in your head, or you might be thinking of words beginning with B, or just trying to add that additional stimulation. Those challenges that can add benefit too. Yeah. Brilliant. Thank you so much. We've got an awful lot to think about from both of you. The explanations of the different treatments, both medical, medicine management and non-medicine management are massive, and we're very grateful to you both for enlightening us about what those symptoms are and how we can manage those ourselves and seek help to assist us with that. And we look forward to hearing the thoughts and questions from our attendees and seeing you both again for our live Q&A session.
Hi, everyone, and welcome to session 2 of Park On. I'm Rachel, and I am a research communications officer at Parkinson's UK. I am joined today by Richard, Andrea, and Claire for the Q&A session. So to kick things off, I would like to ask Richard, so what are the rules with regards to food and taking levodopa? Do you take with or without food, half an hour before, an hour after? And there seems to be conflicting information. So is there anything you can add and clarify about that?
Okay, so very helpful question. So there's no hard and fast rule. Usually if you take it with food early on in the disease, it's not really going to affect the absorption too much, so that's all right. But sometimes we do suggest people taking it with food because if they feel a bit nauseated with the tablets, that's helpful. Later on in the disease, we'll often suggest you might take it away from food because when you're more dependent on how well it's absorbed, there might be issues around about that. So people might find, so particularly if you take levodopa with like a high protein meal, it doesn't get absorbed so well. So generally, there's no hard and fast rule, but if you feel nauseated, then maybe try taking it with meals.
Excellent. So we have another question that's come in from Andy. So his question is, what factors, whether that's genetic, symptoms, psychometric, or anything else, should be taken into account when determining the most appropriate or most likely beneficial therapies? And he's saying that it seems neurologists sometimes just prescribe what they prescribe.
Okay, I mean, again, I mentioned in the talk about I was involved with the NICE guidelines, and we've said that different drugs can be taken, but generally the first line drug is levodopa. There are specific things that might guide that. So in younger people who get at a much younger age, we might use other agents first before we use levodopa. There are particular reasons why you might not use particular drugs. So the things like the monoamine oxidase inhibitors type B, rasagiline, selegiline, you wouldn't use if you're on antidepressants because there's potentially interaction. And I think if someone has got a history of impulse control disorder or gambling or something like that, you'd be a bit wary about using the dopamine agonists. So it's an individual thing, and you weigh things up. But I mean, levodopa is still the one that is recommended as the most effective. And sorry, just one final point is you mentioned genetics. At the moment, no, but you can see that in the future there's lots of research going on, and it may be that we'll look at people's genetic profiles and think, well, actually these people would respond best to this type of drug, etc. So there's already evidence coming up about that, but it's not reached clinical practice yet.
Okay, we have a question for Andrea. So Val has said she has found it impossible to locate an LSVT loud class. She was wondering if there is a more effective route to finding this and if it can be found online. Okay, so LSVT is a specialised programme delivered by trained speech and language therapists, so it does need to be delivered by people experienced in that area. What I would suggest is talking with either your Parkinson's nurse specialist, speech therapist in your area, or your local Parkinson's advisor might be able to guide in terms of what's available in the area. It may depend if there's not a therapist in your specific area. Unfortunately, at the moment, they're not able to deliver that session. It is quite an in-depth programme that you do. In the future, they may start delivering things online. I know it has been face-to-face prior to the last 18 months, so thank you. Okay, we've had a question come in from Donna. So she has said that her father has recently gone into hospital and unfortunately they messed up his Parkinson's medication, which meant that he had severe hallucinations, psychosis episodes, and paranoia. So she's wondering if this is normal for coming off medication.
Okay. it's thanks for that question. It's a very common occurrence of when our patients come into hospital that they may get episodes of hallucinations and potentially psychosis. And the key thing we tell the junior doctors to do is to work out, is there something that's underlying that? So is there an infection that sparked this off, in which case you need to identify that and treat it, whether that might need antibiotics or something. Generally, we will try and keep the Parkinson's medication the same and keep it going. But if people are on dopamine agonists, you might want to reduce the dose of those if people are becoming paranoid and having increased hallucinations. And you might well also stop the monoamine oxidase inhibitors type B. Again, it comes back down to the last drug you would tend to reduce or stop is the levodopa. But we do know that, and Parkinson's UK are very adamant about this, that it's really important that patients, when they go into hospital, continue to get their medication on time. And there's a big drive around that around the country. So because if you don't get that, then people with Parkinson's, often it takes them a lot longer to get back to how they were afterwards. So it's to try and maintain that medication. But thinking about psychosis, there are particular drugs that we use, but there are lots of drugs that we can't use in people with Parkinson's. So again, that's quite critical that the doctors in the hospital are managing these patients are aware of that. So key things, look for what might have precipitated it, identify that and treat it if possible. Try and maintain the Parkinson's medications, but you may have to cut it down. And there are particular drugs that we might cut out first.
Okay, thank you, Richard. We've had another question come in from Isaac, who's wondering how long till the body gets used to the drugs and until they become less effective?
Okay, that's an interesting question. So it's not really a question of the body getting used to the drugs, because what happens is it's a progressive condition. So over time, you lose more and more of your dopaminergic neurons and more of the dopamine that you have in your own body, and you become more dependent on the drugs that are given. So it's not really the drugs becoming less effective. It's just we actually need more drugs to replace what's missing, if you like, a bit like a diabetic needing more insulin to replace what's missing. So it's, the drugs that we use as the disease goes on, we will end up potentially using more different types of drugs, increased frequency of doses and bigger doses, but again, balancing that against the side effects. So it's really due to the progression of the disease that this appearance of the drugs not working so well happens.
Okay, thank you, Richard. We've got another one for you. So someone has asked, what are the alternative medications available for those people that have a feeling of choking while swallowing tablets?
Okay, so there is, as I mentioned, there's a formulation of a dopamine agonist called rotigotine, which can be given as a patch formulation. So if you really don't like taking tablets, then that is one thing that you can do if you're on a dopamine agonist. The other thing is that you can have dispersible Matapar, so that's a dissolvable form of levodopa, which sometimes people find that easier to swallow than actually tablets or capsules. And there are different formulations of the levodopa, either comes in capsule formulation or tablet formulation. But yeah, those would be the choices. I mean, well, obviously, if you're getting on to other therapy, you can then think about apomorphine and deep brain stimulation, but I think that's kind of further down the line, really.
Yeah. Okay, and one final question. So Geraldine has asked, are Cinemet Plus tablets the best way of taking levodopa?
Right, levodopa is levodopa is levodopa. So some people will be on Cinemet, which is actually cocaryl-dopa. Other people will be on Matapar, which is actually cobenzyl-dopa. And there are different, you can either get it where you have it generic, where we just prescribe the cocaryl-dopa, or whether we prescribe it by the drug name, which is Cinemet. The bottom line is different things to different people in Parkinson's, and some people find that they can tolerate cobenzyl-dopa, Matapar, better than they can tolerate Cinemet, cocaryl-dopa. So sometimes if people can't tolerate one, we will actually try the other. So it's a question of what suits individuals, but most people will tolerate any of those drugs.
Okay, thank you, Richard. And thank you to everyone that's joined us on the Q&A today. Hope you enjoyed it. We're now taking a short break for lunch, but join us again soon for session 3 of Park On. Thank you.